There we go.
Hey Mo,
Hey, Ricky.
how are you?
I'm well. The doctor is in.
The doctor is in. We're a little bit late. We had a little technical difficulties today, but we are here and we are ready to rock. And today we have one of our favorite docs, Dr. Kimberly Cursine, and she's awesome. And we're going to talk about palliative care. What a palliative care, and so many people get that mixed up with hospice and say, oh, I don't want to do palliative care. I'm not ready to die.
Yep.
I don't want to die yet. And that is not at all what it is. Not at all what it is, right?
Right.
So we'll dig into it. So Dr. Kim has her titles take up a whole page. So
None of which are very important.
But all richly deserved. All
richly deserved. Yes. So
good.
Why don't we want to jump on in? You want to tell us who you are and what you do, and help us understand what this is. And I'm actually in Jamaica today, you guys. So I'm trying to make it work from here. So
No, you're doing great.
Yeah, well, I'm very glad you're out there living your best life. So that's actually a good way to start. I'm Dr. Kim Cursine, and I'm Director of Outpatient Supportive and Palliative Care for Emory Healthcare in our Palliative Care Center here in Atlanta. And then I also direct palliative care for Winship Cancer Institute. So the people often ask, what is palliative care? I've had several patients ask me that today. And what we are, or who we are a team. And this team is there expressly to help support you through your serious illness, no matter where you are in that stage of the illness. The goal is to help manage the physical, emotional, spiritual, and social distress that your illness is causing. And it's also there to help you have the best quality of life possible. We also, in addition to that.
Can you say those again? Can you go back and say those again? Because that's so profound.
Yeah, so we try to help people manage the emotional, the physical, the spiritual, and the social distress that the illness is causing. And when we say that, we say you, or we think about the patient, but we also think about the person as a whole, and as well as their family unit. So palliative and supportive care not only supports the patient, it supports the family, and it also supports whatever the goals are for the treatment or the goals in the plan. The question we also have is, well, if you do that, then where does hospice come in? So explain it like this. If you are being treated and the goal is for you to be cured, but the symptoms are really rough, then we're going to manage those symptoms and really focus to help you get across that finish line for that goal. If you are now have a serious illness and you are living with it, then it's our job to help support that plan and to help you live as fully as possible and manage the symptoms while you are going through that serious illness. And that could be for a very long time. If unfortunately, if the illness cannot be cured and it's progressive and you're coming to the end of life, then palliative care will help support you there. And that's all hospice is. Hospice is an insurance benefit there for people who are at the end of their lives to make sure they have full support, medical medications, DME, as well as intensive medical care. Because usually, we always think of aggressive medical care upstream or like in the ICUs. But when you are very ill, and even at the end of life, you need intensive medical care, and that's what hospice provides. And that is a type of palliative care. That's the vehicle we deliver it through. So I deliver my palliative care through the vehicle of the clinic, and the patients who are coming to me are often on active treatment or living with their illnesses, and we're trying to help them do that, and also help clarify and translate what our oncology and our surgical oncology friends say.
That is fair. I have questions though, because how is it that So you said manage the physical, the psychological, the spiritual. I didn't know if you said nutritional, but I bet that's in there somewhere too. How can one doctor be all those things? Tell me about
Right.
how the team in the village, because it's got to be a village, right?
Oh, it's definitely a village. So one person can't manage all of those things. So when you get a palliative care, in most places you get a palliative care team. And so on that, traditional members of that team may be a doctor, social worker, that sometimes there's RN case managers, spiritual support. Depending on the depth of the team, like particularly for children, there may be lifestyle, like child specialists. Some programs have music therapy, pet therapy. They're all
Mm.
they're all, if you visited one palliative care program, I think you have visited one, but they all have one central goal, that it's not just one person. It requires it requires us to tend to all parts of you. And so the doctor may be the leader of the team, and they may be helping figuring out where you're going within the interprofessional team, but you really need a team to do this. I have plenty of patients who come to clinic
Yeah.
and they don't come to see me. Like they're like, hey, Dr. Christine, I'm looking, and they come and see my fantastic spiritual health clinician, Janet, because that's what the problem is. And I'll go ahead and manage their pain and their symptoms, but I'm not the star of that show. So what I love about this is that you really can use that interprofessional team to its most ability, and maximize it.
That's great. That's great. So who's on your team? So you just,
I'm really lucky. We have advanced practice providers on our team. We have 2 licensed clinical counselors. And then we have a master's prepared social worker, a spiritual health clinician, and medical assistants. And here at the Winship Cancer Institute, when we're working with cancer, the palliative care works under supportive oncology. And under that umbrella, in addition to us, patients have access to integrative oncology, which includes a naturopathic physician, acupuncture, all free, by the way, which is
wow.
amazing, at this institution. And there is nutrition, there is cancer rehab, and there's cancer pain, and there's cancer psychiatry. So one of the out of all the professions, kind of cancer has sort of figured out kind of how to do this, and patients are able to kind of move around and figure out which part they need. Where palliative care kind of sits in a world that has that many resources is oftentimes we end up sort of being the navigators, where patients may bring things to us. And if we cannot solve that problem, then it's our job to get you to somebody who can solve that problem. So I often tell patients, if you do not know where to take it to me. I may not know what to do with it, but I will find you somebody that can. And the reason why we do that is because that actually relieves the distress. Our goal is to try to help mitigate suffering. And if what you're suffering from is you can't figure out who's going to fill this medication, or figure out where to go, or can't get in touch with your doctor, then we do that as well.
Now, this is a
Wow.
very, I think, and maybe it's more commonplace than I think, but what I'm hearing is a very unique model of, one, people being able to get multiple things they need from one clinic, right? So it's not just you get your, because the way it works in my office, you get your surgery here, your medical oncology, your chemo across the hall, your radiation, down the road, and it's all sort of disjointed, but it's kind of a one-stop shop in terms of offering these things, but also there's different providers. Is it like that in most other community settings, or because what I find is maybe there's just one doc who then is sort of trying to figure out and ends up being a bit of a case manager.
Yes.
How's this model different and unique?
So this is, so our model, because we are with the academic center, or maybe some of your larger standalone cancer centers, they will have these kinds of resources. They'll have palliative care teams that may be fully fleshed out and are, what we consider like the ideal. There's a disparity, though, when you get further out in the community, the ability for smaller hospital systems or smaller practices to sort of afford that interprofessional team gets difficult. So you may find that if you're in a smaller area, there may be palliative care, but you may not have all the complements. But the reason still to go is because even if they don't have all the complements, they know where all the complements are. And when I've worked in smaller systems before, I used to say I have a magic cell phone. Like if I didn't have it on my team, I go find somebody who has it. And the unique thing I think about palliative care is that we understand what you're needing at the time. We spend a lot of time listening and a lot of time trying to make sure we hear you, and also make sure that we're delivering the type of care that you need at the time that you need it. So I think that's what helps some of the smaller programs. There's also community-based palliative care. So there's palliative care delivered by the community, and they actually go into people's homes. Like sometimes I'm pretty sure people out there have been so sick that they can get from the infusion chair to their house and then back to the infusion chair. Or you live really, really far away and you can't make multiple trips. So in-home palliative care has really bridged that gap, but particularly in rural America, where they can provide the services inside the person's home. It's not requiring them or asking them to give up anything. It's really adding that support. And insurance companies like Humana and United and Aetna have all gotten into the business. They realize that if we support our patients and we help figure out what they need, then things go better for us, things go better for them. So they will often have palliative care teams, often provided by insurance companies.
Oh, wow.
So, yeah, so there's a lot of work. There's a lot of thought going around this. Medicare Advantage is about to get involved, so are involved in strong palliative care. And that's a really good thing, because then that allows access, it widens access. And there are some insurance companies are doing something called Cancer Concierge. And they're amazing.
Wow,
Tell
that's
us
pretty
more
cool.
about that. Cancer
Yeah.
concierge,
A
yeah?
cancer concierge. So I learned this from one of my patients. She has a very nice insurance plan, and they developed a cancer concierge. And what that person does is they really help her navigate her benefits, and they communicate back and forth. So if there's something that I would like for my patient and I wonder if we can do it, I work with the cancer concierge. And so instead of me banging my head against the wall trying to convince the insurance company why I want to do this, they actually serve as an advocate, and they can explain to me what the boundaries are. They explain to the patient, but they also help advocate for things that the patient needs that may not be apparent to people working at the insurance company, because oftentimes some of them may not have a medical background. They're working on a different. So
And is that sponsored through insurance, these cancer concierge, or is this a service you find online, like
no,
through a
that's
website?
that is sponsored through insurance companies.
That's
Yeah.
pretty cool. That's pretty
Yeah.
cool. So Dr. Kim, we have a couple comments and I'm from about the spiritual role that you talked about earlier. What'd you say? A spiritual health clinician?
Yeah, so we call them, people will also refer to them as chaplains. And I like the term spiritual health clinician because I feel like that's really what it is. So, spirituality is a huge part of a person's life. It's also, sometimes it's the anchor, sometimes it's the way you make decisions. So if I'm having a conversation with you and you are making decisions from a spiritual place, and I don't understand that, then we may never be able to get together. If you're telling me that if something maybe not going like I hoped, and you say to me that I don't claim this, or, I live in faith, if I'm not familiar with that, or if I don't have a general understanding of what that means, I could misinterpret that. I could blow by that. I could condescend to that. I could dismiss that, not meaning to, but it's really because I don't understand. But when our spiritual health clinicians come and they have those conversations, they do understand what
Mm.
that is. They do understand that anchor. And it reminds us that people just don't make decisions based on the numbers. There's a variety of things. There's values. And spiritual health clinicians aren't attached when they're working in that role to one particular religion. They may have one of
Okay.
their own,
Mhm.
but what they're trained to do is to deal with the spiritual distress.
Yeah.
And spiritual distress is going to be questions about dignity. Where do I fit in the world? Having the correct conversation, like, why did this happen to me? Having a safe space to maybe not be, however you believe, if you believe in a higher power, you may be a little angry with your higher power.
Yeah.
Mhm.
Losing your faith or having, yeah.
Yeah,
Or
but if you
making those
talk to,
faith-based decisions, even
Yeah.
end of
Yeah.
treatment, when to stop
Yeah.
treatment, when to start other
Right.
treatments, all those things. Yeah.
all those
Right.
things, yeah, you have to count that in, and you need a space, I think, to be able to say things, the unsayable. You need to be able to say, I am angry, I don't know why, maybe I'm angry at my God. And you say that to maybe your church community, or maybe even to your pastor. And sometimes what you get back is, well, pray more, have faith, you're going to get through
Right.
this.
Right. Right.
And that's not always helpful.
Right.
So when
Right.
you talk to somebody and there's no consequence, you can really be honest. You can explore things that are maybe harder to explore, things that are harder to heal,
Mhm, mhm.
ask questions that might be upsetting to the people that love you. Because even if you talk to your friends, there's an expectation of a relationship. And you still have to give out and be cognizant of another person's feelings. When you're able to speak to somebody without that expectation, then that's really just for you. And that's the place maybe you might feel the ability to be most honest, because there's no consequence.
That's
Now,
really interesting. Wow. When you say it's harder to talk to your friends because it's a relationship. So this makes it easier because you can sort of step away from any kind of sort of, well, that's pretty cool to think about it that way, right? And I think also maybe some help there would be with your family, because I often see families where the patient has sort of come to realize that they've got this disease, whether it's metastatic or not, and sort of find peace with it, but the family is still really angry.
yeah.
And maybe angry that, well, we prayed for this and it didn't happen, so I think that's a really good, comforting place to have some support.
It brings up a question though, because are palliative services available for the caregivers and the support team and the ecosystem as well?
Yeah, that's part of what that is part of what we're designed to do. So we're not only designed to take care of the person, but also there for caregiver support and family support. And why that's important is because although we belong to ourselves and we have autonomy, the world doesn't work that way. So whatever I choose to do or not choose to do, obligates the people who love me to accept that and walk in that, and also deal with the consequences of what I have decided to do or not do. So I often say people that, couples, like, hey, the cancer is happening to you, but it is happening to you too. You experience it differently, but it's happening to both of you. Things have changed. So having a team that is able to sort of recognize that and be sensitive to that and be a support for the caregiver who could be crumbling under the weight, or sometimes upset, angry, and resentful.
Mhm.
Yeah.
And that's not acceptable.
Right, right.
So there's all these complicated kind of family dynamics, but you can't tend to the person if you cannot tend to the people that they love.
Mm,
Right. Well,
that's
I
pretty
always say
profound.
that, yeah, but I always say that tumor in your body is a lot of people's tumors. That
Mhm.
tumor affects everybody in your family, in your house, in your job, in your community, in every organization you belong to, like in the neighborhood. You think about that tumor, it's just not one person's tumor. It affects everybody in some way, right?
Oh yeah. It's
So,
we often talk about goals and we say, well, what would you like and what would you want? And that's an important question to ask. But the other question you got to ask, because it's often incomplete, like, You told me what you want. Now tell me what you got to do.
Mm,
Because sometimes they're not
that's true.
aligned, right? You know, if
Mhm.
something happens to me and I'm very sick, I'm going to want to be comfortable. I have a 6-year-old son. If he says, Mom, I don't want you to go, I'm going to do everything to stay here. And I'm a palliative care physician. And so I don't want to do those things, but I love him more.
Sure.
And so I think being able to sort of get those, and teams like ours can sort of help not only the patient and the family, but also help communicate with the other providers, the hospitals, and the other people taking care of you, who really, really want what's best for you, but sometimes cannot understand why you are doing this. And
Mhm.
and that creates this divide and this tension. But having maybe this go-between or this intercessory to be able to say, and that advocate to be able to say, hey, this is what they want. This is how we're going to help them through it. You are doing exactly what they asked for as their health provider, and making sure that glue between the care team or the oncology team and the patient stay tight. That relationship needs to stay tight and trusting. And so sometimes we just add a little mortar to keep that together.
Mhm.
Mhm.
We have a question in the chat about whether or not and how palliative care can be helpful for other disease states, right? So sickle cell was one that was brought up. My question
Yeah.
is a little bit inverse to you in that do clinicians specialize in oncologic palliative care? Are there opportunities to sort of treat broadly, or how does that happen in your training? And for people who are watching who might want to get involved in palliative services, how do they sort through that
That
pathway?
is that is a great question. So like every part of medicine, we specialize and specialize. So, and that's happened for us as well. So I think a lot of palliative care may have birthed out of oncology, and a branch birthed into geriatrics and dementia, and we did that really well. But now that we're maturing more as a field, there are people who specialize in neuro palliative care. We have surgical palliative care. They actually have their own society. They have a pamphlet. Yeah, it's amazing. Surgeons that
Wow.
focus on
Wow.
palliative procedures. We have cardiology
Love
is
it.
huge, heart failure, heart transplants, congenital heart disease. There's pediatric palliative care. So for almost every ailment, there is some form of palliative care. And many clinics, most of us, you'll see a lot, like in the cancer centers, they tend to focus on oncology. And I think we have a way, and geriatrics and dementia, I think, is taken care of. But other disease states are growing. I'm a generalist. I love taking care of cancer patients. I do that, but I was trained as a geriatrician and did a lot of role medicine. So if you come to me, I'll palliate it, whatever it is.
I
And
love that. That's a verb, palliate. I love
yeah,
When
that.
you
like,
right, when you
like
come to me, I'll palliate whatever it is. I
even if I
love
don't
it.
know what it
I love
is,
that.
even if I don't know what it is, I go on PubMed and I'll figure out what it is and I'll palliate.
We're gonna get you a jacket that says the palliator.
I love the palliator. Well, you know what though? Interesting, because my mom is 90, my stepdad is 92. And my mom actually has COVID now for the third time. She's fine, but she has COPD and she's on oxygen.
Mhm.
But and she has a great geriatric team at Walter Reed, but I never thought about asking for palliative care for her. You know what I mean? And I think she's got a good team in helping her do physical therapy to help her get around better. But I think this could add another level of care for her that I never really thought about. I mean, I'll
Love
think
that.
about that.
Sort of think about it like I tell people to think about it like a precision. I think we started out as always coming into people's lives very late, and that was helpful for some, but not as helpful. And so then we thought, okay, then let's come into people's lives early, right at the
Yeah.
time of diagnosis. And that seems logical. But the truth is, life doesn't compartmentalize like that. And
Right.
so in practical world, because every medical care, we don't have universal health care, everything's a cost, everything's a charge.
Right. Right.
And and when you're ill, 50,000 doctors and visits are really
Right.
hard. So I think the kind of way to look at it is, if you have a team and they're meeting all your needs, they're giving you good primary palliative care. right? So it's like you
Okay.
would go to
Okay.
your primary care physician to manage your hypertension. You don't need to
Okay.
go to a cardiologist.
Okay.
However, if you have an arrhythmia, then you need a specialist. So
A
if things
cardiologist.
are going good, you don't need me. When things are not going good, that's when you need me.
Okay.
And sometimes just right before. So if you see, like I say, the wheels are coming off the bus, and there's always warnings. We're going into the hospital more. Where
Right.
our breathing's getting worse. We're starting to maybe withdraw. The medical team is doing all of this and we're not getting anywhere. Or there are things they don't feel comfortable with. Like you say, hey, I think my mom could use this. And they're like, oh, we don't do that. Once you start seeing that kind of thing, where you're not getting the responses you need, now you know they're pushed outside their comfort zone. That's when you need us.
I love that. You said good
Yeah.
primary palliative care. Like there's a
Mhm.
baseline of care that can be
Right.
palliative, not provided by a palliative specialist.
Right.
That it
Right.
sounds like to me is the baseline that everybody should be looking for
Right.
from their
Right.
general physicians, from their oncology team, et cetera. And if we could maybe strike a better balance, we could have more services available for people who are in need of the extra mile of services, right?
Absolutely. And this goes back to really training. So we have to make this shift in medical school. So what we do is we teach people about the beginning of an illness. We teach them sort of kind of the middle, but we don't teach them, but we don't spend any time on how it ends. And, and that doesn't mean, 1 or 2 days. End could be the years. Like
Right.
you live
Right.
with advanced
Right.
heart failure for years.
Right.
You live with COPD for years.
Right.
And where it's not going to be cured, but you can have a really great life. So if we can change the way we educate and think about teaching our medical students and our residents the continuum of care, give them the education on pain management, give them the education on the symptoms to manage these things, that'll help them feel more confident, and also allow for the communication skills that make a lot the difficult conversations a little bit easier. Then that would prepare them to provide good palliative care. And then when the needs start to outpace what they can provide, because remember, primary care providers
Right.
are supposed they get 15 minutes a patient, so you can't do everything, but
Right.
it gives them the recognition to know when they need to get their specialist involved. So I think, it's we need a good combination of both.
Right. So we have so many breasties who are struggling through chemo, and just the side effects are horrible. And all the side effects that we deal with them, like just the nausea, the fatigue, but also just dealing with our daily lives. So it's always not about the nausea. It's about, can I feed my kid today? Can I go to the baseball game? Can I with my son? Can I take care of my mother, or whatever it is? So I don't know, can you play a role there in terms of helping people kind of balance their life, whether it's spiritual, emotional, whatever? I mean, I think we often get therapy, but not everybody does.
Mhm.
You know what I mean? So I think it falls in different buckets, but.
And that's the way we kind of look at symptom management. So when I'm asking a person about their pain, what I'm really wanting to know, we always start with, what is your goal? What we're asking is, what is it that you want to do? What is it that you need to do? And once you can tell us that, then what symptom is preventing you from that? Is it pain? Is it nausea? Is it depression? Is it anxiety? Is it everything? And then once we have that goal in our head, whether it's to get to that soccer game, to be able to, whatever you have decided that you want to do, then the symptom management needs to be tailored to help you do that thing. If that makes sense. Because sometimes when the opposite way is sort of going down the laundry list, and then you fill out the numbers, like on a scale of 1 to 10, all of that's great, but that doesn't mean a doggone thing if I can get all of those to 0 and have you a zombie on your couch and you can't do what you want to do, and you are miserable. I can get your pain under control, but if you can't engage, then what was the point? So the way in which we look at it is, what level of functioning is going to be acceptable? What is it that you need? what are your obligations, what are your wants and dreams, and then the symptoms overlay that and try to figure out which one of these things is bothering you the most,
Right,
I
and
love
start
this
to
approach.
unravel.
right.
And I love it because we're taught that there's a distress thermometer and the goal is, if somebody's at an 8, get it to a 2 or get it down as low as possible. But you don't really think about the fact that, in doing that, you may obliterate that person's motivation, their drive, could be their sex drive, could be their energy level, et cetera. And it's a very thoughtful approach that you're mentioning. That I wonder, is there formal training that's not in the form of fellowship? Because I get that, truly to be a palliative care physician, there's additional training that you need. But what's happening in the medical education world, that in the social work world, in the worlds of, sort of the oncology unit as a whole, that helps us to better understand how to think about this?
Now, that's a great question. There is what's starting to emerge now in our field are mid-career fellowships. So where, in order to do a palliative care fellowship, you have to stop your job and for a year dedicated to that. And that can be just financially limiting, not everybody can
Right.
do that. But mid-career fellowships that spread the training out, but allows the person to continue to work. And so that's one way, I think, and that's a really smart way to kind of increase our workforce. There are master's prepare programs that exist. There's PhDs in palliative care that you can obtain. And there's a lot of great training. So there's a lot of great training where there are conferences, there's modules. And so you can spend time learning. So I think that if there was a person out there that really wanted to think about how they could get into this field, but not become destitute, then, a mid-career fellowship. If you think that, hey, this is something I really want to spend my life in, but I still want to kind of stay what I'm doing, then maybe a master's prepare program would be helpful. So I think, and this is happening in medicine in general, trying to think about ways to sort of stretch our workforce. We have wonderful advanced practice providers that are entering into this space. Social work has certifications. Pharmacy has certification. I forgot, we have a palliative care pharmacist. Yay! That's like the holy
That's
grail.
pretty cool. A palliative care pharmacist to help with just the drugs related to palliative care, huh?
Yeah, because I laugh sometimes. I'm like, now you're on 27 medicines. I'm pretty sure that now we're just giving you medicines for the medicines that we gave you.
Right.
Everybody in that audience has a shoebox of something you took once or twice.
Right, right.
So
Right.
It's so true.
yeah,
Right.
and sometimes what you need when you're having lots of symptoms is to really understand how the medications you take interact with each other. And it can be very subtle. So what we really want to do is make sure that to give your treatments the best chance, we have to make sure we're not doing things to undermine that chance. And that's, I think, what makes having a pharmacist so important, is that they're our check to make sure we're not doing things, practicing crazy medicine, thinking we're helping and making things worse for you. So yeah, and but taking advantage of that is just incredible.
Well, can we talk about pain a little bit?
Yeah.
When I see so many of our metastatic breasties in pain, and the whole concept of, is your pain a 1 to a 10? Like, that's like, to me, is so ridiculous. But, I mean, like, and I've watched many breasties, like, I'm way beyond 10. Or what does a 10 mean? Like, what is, how do you even articulate how you feel? And the smiley face thing is even worse, right? Because there's no smiling happening. But, how do we help people even articulate their level of pain to a doctor to get the care that they want? Because they'll ask me, like, I don't know what to ask for. They've got, and they're loaded up with oxy, but they're all afraid to take the oxy. Then they're saying, well, should we smoke marijuana? Like, should I do all these things? Could I do CBD? Or and they don't, and they're lost, and they're suffering. They're suffering, and they don't know what to do. And some doctors don't even want to talk to them about, they just give them oxy, and the oxy has all this stuff. That's,
They're reluctant to talk about CBD and other
yeah,
modalities that, yeah, that we don't know about. It's almost like if we didn't learn it, it doesn't exist.
Yeah,
And we're getting better at it, I have to say, as more medical oncologists and other providers
yeah,
become
yeah,
licensed to prescribe these things, but the
yeah,
learning, the education there is still so pharmacologic, right?
yeah,
right,
Yeah.
yeah, yeah,
Yep.
yeah. But they're
Yep.
staying in pain, but they're in pain and they're suffering and they don't know what to do. And then they feel like, if I smoke marijuana, is it going to interfere with the pain meds? And like, there's a
Mhm.
lot of confusion around how to get rid of the pain,
Yeah. And there is, and it's not helped by society has, and we have too in the medical profession
Yeah,
start to criminalize pain management.
yeah, yeah,
So your breast cancer patients who have like pain and we can see the lesions and they're going through active treatment, are gonna get oxycodone rained down upon them with very little
yeah,
question.
like sprinkle, yeah, right, yeah,
But those with
yeah,
no evidence of disease has had mastectomies and radiation, and they continue to hurt on all of that love and things that we showered upon those people all of a sudden disappear. And if we can't see it, then you must not feel it, and they don't know what to do. Or
right,
we have bathed you in opioids, and then all of a sudden it's done, but the body doesn't work that way because, prolonged exposure changes the way we think, it does things to our brain, it changes the way we perceive, the pain. So the pain's there, but it may be driven by other things. And we don't even fully understand how all of that works. So I want to just sort of put out there that pain is a mess, and we have made a mess of it and made everybody nervous about it. But if one of the nice things, I think, when you are working with a palliative care provider, the holistic way we should be approaching pain is approaching not only what you're experiencing physically, but also how it's affecting you mentally, emotionally, and functionally.
yeah,
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 because not, for some
right,
people, they have 10 out of 10 pain, and
right,
they're okay with that. If they're nauseated, they're about to like lose their minds. We have people who have 2 out of 10 pain, can't tolerate it. They just become undone. So I think the way we should think about it is, what is the level of suffering, and manage to the level of suffering. So, and our scales, you're right, our scales, they do give us some information, but the question I like to ask is, what's the pain stopping you from doing? What is it?
Mm.
What is it
That
that,
is so good.
That is so good, that's so good, I'm putting that in the comments.
yeah.
Yeah.
But we do have to say, and this is a hard thing to say, it's a hard thing for us to say, and it's a hard thing for everybody to hear, that our ability to get it to zero like it was, we don't have that ability.
Right,
And we are very reactionary to pain. It is difficult to be proactive to pain.
Mhm.
And one of the things I would love to see is preparing people not only for the treatments they get, but also getting them mentally prepared for the pain and discomfort, and getting people to cancer pain management specialist early.
Yes.
Like, let's not wait. If you know that you are going to do something painful to somebody and block a whole bunch of nerves, let them know that there are these wonderful people that could help early, instead of waiting until things have fallen apart.
Mhm.
Getting palliative care involved early, getting cancer rehab involved early. I mean, I feel for patients who have to take aromatase inhibitors.
Yep.
That
yeah,
joint pain, imagine every time you sit down,
it
you
hurts,
ossify.
Yeah.
right,
So every time you get up, it hurts. And it may not be hurt like you're falling on the floor, but imagine living every day of your life for 5 years when you have to move.
Mhm.
You just can't get up and go.
It's such a quality of life issue.
Yeah.
Yeah.
It might start off and you're feeling strong, but after year 3, you just want to be able to get up and go to the bathroom without hurting.
Mhm.
right,
And you cannot do that. So I think sometimes we think the level or the intensity of the disease matches the pain, but it's how the pain is causing you to suffer. It's what it's
Right.
interfering with and taking from your life. And that is emotional, but it's also psychological. So I tell people the pain is real. It's not imaginary pain. But once it has affected you psychologically, then just managing the pain won't help if we don't deal with the distress it caused. And if we only deal with the distress it caused, you're still in physical pain. So we have to figure out a way to be able to manage both in a way that keeps you functional, but not makes you feel like a pill factory. But I do think that if I would tell your audience anything, being able to articulate it the best way you can and sort of not accepting that, don't accept that it's not real. But try to have those conversations that, I understand that my pain is real. Can you then tell me what we can kind of do about it? And really seek out providers that can be helpful. But but we live in deserts now, and we live in places where people do not have access to that. So I think we need to be honest. So as we are advocating, and Ricky, I love that we advocate for clinical trials. We want everybody in a trial if they can be in a trial, but we need to be advocating for quality of life. Like, if I'm going to do your trial and it's going to make me feel all these ways, then I need to have symptom management. I need to have this maybe be a part financially covered. Like, we cover the medication, we cover the transportation, cover what is wrong with me, and maybe I can hang out in your trial a little bit more. Maybe
I absolutely love that.
Right. And that's why we have, we just started our Nurse Navigator program, Dr. Kim, because now Val can kind of be that support to when kind of identify what the issues are, and then bring you into the equation if we need palliative care for the patient. So I think that's we're trying to deal with that too. But you hit on something so great. And I always think about my dear friend Allison, who passed a couple of years ago, but I suffered the pain with her for 2 years, but you made a good point about it's not only the physical pain, it's the psychological pain that goes with it, because you're so angry about why you have the pain and why you can't make it go away. And there is a whole psychological piece that I never really thought I couldn't articulate until you just did just now, that it is a thing. That's two parts of it. It's not only the physical pain, but it's all that, gosh, why am I dealing with this? And why can't they fix it? And why can't I take something better? Like, there is an emotional part of it that you don't even think about. I think also, though, as you are, and I'm probably now moving a little bit more into sort of hospice, but I think I wear a jacket that says "Fight Like a Girl," and I say "Fight like a girl" all the time. Fight like a girl, fight like a girl, and to everybody that's struggling, fight like a girl. But there's some point where you have to, like, I don't want to fight anymore.
Yeah.
And I think it comes before you get to hospice. It's like, how do you get to the point where you say, I'm tired. I'm tired of feeling this way.
When there's lessons in surrender too,
surrender. I think that's a whole emotional, psychological thing that you have to go through before you can even get to push the hospice button. Does that make sense?
Oh, it totally makes sense. And this is why the fight metaphor can be really helpful, especially for our culture. There's things happening to me and I'm going to fight it. And then what we do is we overlay all these human qualities and emotions to this illness, right? This illness is trying to hurt me. This illness is trying to kill me. And I think it helps people get through. But the cost of that, and the problem is that illness, no matter what it is, takes your self-esteem and your sense of self away. Like, you have a sense of self, you and your body got a deal. Me and my body is going to go here. We're going to, we got a plan. And then your body goes and does something else. So that's the ultimate betrayal. Now your body went off script. I mean, your brain's like, hey,
who are you? Where are you going? Who are you?
Why are you doing
off the rails? Yep.
Off the rails. And so now you suffer one betrayal, and that's demoralizing. And then we tell you to fight. Okay, so I'm in the fight, right? And then we say, oh, she lost her fight. So what that implies is that you did something wrong.
You didn't work
Right,
hard enough.
Right,
You didn't
right,
fight
yeah.
hard.
Yeah, you didn't work hard enough. So now you're
Right,
doubly
right.
demoralized. So what I try to reframe it is that I tell people all the time, like, this is not your fault. I said, this is something that is. I don't know why it is, but this is something that is.
Yes.
Yeah,
And it is, and what we want to do and what we're trying to do and what you're hoping to do is figure out how do we take this is and how do we live with it? How do we live with it?
Mm-hmm.
And when the time comes and all this treatment that you're getting, you didn't fail. It gave you time. It did
Right.
exactly what it was supposed to do, but it
Right,
gave
right.
you immortality.
Yeah.
right.
But
Right.
it gave you time and you didn't fail the treatment. No, you did quite well,
Yeah.
but the treatment wasn't able to fix what is. It just gave you more time to live with it. And in that, and I find sometimes if people can think about it like that, now they can live with the moment, they can release themselves. Now you have control. So, you know what, look, I can go to clinical trials, I can try this, I can move about the country, and it's all my choice. And when I'm done with it, I'm done. You're not failing anybody, you're not letting anybody down,
Yeah.
Right.
and you're not giving credence and putting all these human emotions on an illness that doesn't have those human emotions. It doesn't
It
move
doesn't.
in a logical manner.
It
I can
doesn't.
appreciate that from a spiritual perspective too, because I have patients who feel like they're not honoring their faith by either accepting certain therapies, or I had
Right.
one woman, she felt like God had healed her and then she continued to see the doctors and she continued her therapy, and she said, well, now I feel like it because maybe I didn't show enough faith or I wasn't strong enough in my faith and I should have just let God heal me. And I said, but God brought you to all of these doctors to help extend your
Right.
life, right? To help exercise that faith, right? So that you could look
Right.
at it from a more proactive standpoint. But she was so distraught that she thought that her doing something had caused her cancer to return, and she really, it's a lot of undoing, I think, of some really problematic theologies sometimes. But our minds do go to that place of blame,
Mhm.
of feeling
Mhm.
like our bodies have been betrayed, and how do you reconcile, how do you ever love a body that you feel like betrayed you?
Yeah,
How do you reconcile that?
you got to understand it, you got to deal with it. And when you don't say it, and it's hard to get past it. So even if you've had like I have women who have, they're no evidence of disease, but their body doesn't look the same, but they still want the body they had before. But
Yeah.
something happened to you that was major that has
Right.
changed you.
Right.
So now you have to figure out how to live with this person. But if you keep looking backwards, you're never going to get to know the person that went through this huge life-changing thing and grow and figure out all the gifts and all the things that could come from it. And it keeps you stuck. And we promote it like, oh, you're going to do this and now you're going to get back to normal. No, you're not. You're just
No,
not.
you're not. There is
But
no normal,
But who
Can't
this
go back.
new person is
Right.
probably, if you give them a chance, and you don't waste it, you might learn to love that new person, that part of you and that time, and figure out how to live, with that uncertainty and change and that trauma. And it's a hard thing to ask for somebody because it's not fair. It's not how it should go. It's not right. But
Right.
all those things are true, but you're still here. And so while you're here, then let's be here and let's get what we can and get what you deserve while you're here. But
Thank you for saying that. I tell people every day, you'll never go back there. You can't go back to that body, to that person. And now you're just a better badass. That's what I tell my
yeah,
Right.
but let them, but they got to grieve. And if you can
They
name
gotta
what it is, there was a death that happened, a death of all the things how you thought they were going to be. And you get to be angry and grieve that. So and I tell people, you can visit, but you can't live there.
Right.
Don't live there. Visit and do what you need to do, memorialize it, but
Right.
don't
Look at
live
the
there.
pictures, but keep it
Mhm.
moving.
Yeah,
Keep it
don't live
moving.
That. Wow.
Yeah. Wow. Wow. So many good nuggets,
Mhm.
right?
I would dare
Um,
say it's time for us to have a clinical trial, a palliative care clinical trial, Ricky. And I think
yeah.
that as we look at what the trials are, to really either find or craft one that helps to address the benefit in our community,
Mhm.
because
Yeah.
it seems to me it would be a real natural corollary to all of the
Right.
treatment
Right.
trials to also
Right.
look at how palliative care can
Right.
help to support people on those trials and keep them on those trials longer. You
Yeah.
know, not compliance, but adherence, right? And it helps to mitigate side effects and other things. And the different ways in which our community maybe needs some specific approaches to palliative care. So I'm excited about that possibility.
Yeah,
Yeah. That sounds good.
and they have lots of trials that have shown. There was a Timmel study that showed the benefit of palliative care in lung cancer. And when you Google, there's all these trials, but we're not in those trials in full force. You know, when I see people, particularly Black women, and sometimes I see them early, but most
Mhm.
of the time I see people when the house is on fire and
Mhm.
it's a mess. But when I often see my women, my majority women, they, it's almost like we think they might have a hard time, so we need you to see them. And that is incredibly meaningful. So I get the opportunity to walk through their journey with them, help, navigate, and then help be there when there's really tough times. But my Black women, I'm walking into their lives at the most horrible time, trying to get them to trust me, asking them, okay, do one more, none of this stuff worked,
Right.
but
Right.
I'm
Right.
going to work. So,
Right. Right.
I'm here. And they're like, well, where the
Right.
heck have you been
I
the
love that.
whole time? You know, and that's the thing. We have to get our community to demand symptom management early. We have to get our community to demand that not only treat my cancer, but you need to treat me, and you need to figure out how to treat me, and you need to tailor the treatment to treat me, and it needs to be shaped within my values, because what blocks people from talking to us is, reams and reams of literature that say we won't talk, that we don't want to discuss hard things. You read, just Google it, black people don't use hospice, or they don't want palliative care. It's not that they don't want that stuff. They just don't want it the way you want them to want it and have it. They want it.
Right. Or they don't know what it is. We're
Yeah.
finding so much that we don't know what it is.
Yeah.
And our health illiteracy, meaning we have brilliant people that just don't have health literacy and they don't know what to ask for. And then we have this other guilt about not asking for help, being afraid, I can handle it, I got it. Like I got this. I'm, and then we have the whole thing about Black women are supposed to be in pain. So all these things are like piling up in front of us to keep us from getting to you, but we have to talk about it more.
Yeah. And Ricky, we can't put it all on our community. We're
Right.
not telling.
We're not telling. We
We're
don't
not
know.
telling. As healthcare
Right.
providers,
Yeah. Yeah.
we have been ingrained and programmed
Yeah.
to think that we are going to reject it. So we don't ask these women. It doesn't enter into our minds until it's
Right.
too late. We make assumptions about what they want and don't want. And then if they don't want it exactly, they ask for it a little differently, like, doc, I'm willing to do this, but it's really going to be important for my mom to have IV fluids. Or, I might want to go back to the hospital. Then clearly you don't want palliative care. Well, I really don't want to take these opioid therapies. Oh, well, you don't want pain management. I want to talk to maybe my pastor before I make a decision. Oh, you're religious, and never mind, we're not going to have that conversation. That's, you don't know, because we haven't bothered to tell you, because we're afraid to tell you, because it's like the circular firing squad. So if we get the doctors to realize that we're people, we're multidimensional, we can hear hard things, and it's not that if you really want to know what our goals are, and you ask us what we want, then don't tell us that we're wrong.
Right.
Give us what we want.
Help us get there. Help us get
Help us
there.
get there.
You got to read this comment, okay? This is from Angela Nelson. My mom needs 1,000 cc's of Dr. Kimberly stat.
She said stat. I love it. She used CC's. How can people get some CC's of Dr. Kimberly
I know,
Kersey?
I
How do
know.
we get some CC's and get a dosage in our lives here?
A dosage in your life, I think you have to ask, and it shouldn't be this hard, but I think asking, and there are people there, and so if you can't get it out of university, there are a lot of great people in communities that are in cars driving all around trying to deliver you palliative care. When that nice lady from Aetna calls and says, hey, I would
Ask
like to
her
come
for
out
it.
to your house and talk
Yeah.
to you, go ahead and talk to her. Oftentimes
Right.
they are advanced practice providers who have special training, you know, being sort of willing to figure out how you can get that care. But I think that we're going to have to demand it, like that push, like
Yeah.
if you have such an
Yeah.
amazing organization and you get those people mobilized and people are excited, but they need to be excited about, if I do this and I live, what do I
Right.
do now?
Yeah.
What am I going to do now? What do I
Yeah.
do with the
Right.
pain? All of, how do I get my life back? How do I
Right.
get
Right.
to wellness?
Sure.
Right.
How do I even
Right.
conceptualize what it can look like and
What it
make a
looks like.
plan, right? So that I understand where my goals are and what my goals can be, and the fact that I can even set goals throughout this, that I have some
That I can
power,
have a goal. That I
that
can
I can
have a
have a
goal
goal.
to be healthy,
Wow.
right?
If you're watching, I
Wow.
hope you take that away, right? Like that
Yeah.
you can make goals, you can have goals, and that you might have cancer, but it doesn't have you. It doesn't have to
Right.
take over
Right.
your life in
What are
all
your
those
goals?
ways.
Yeah. Yeah. Wow. Wow.
Wow.
Wow. Wow. What a
So
great
good.
show. Yeah.
Mm,
Wow. I'm putting that in the comments.
so good.
Wow. 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 Well, can you come back again soon?
Yes, I'd be always happy to come back, and I love this. This is such a fantastic forum that both of you have built, and I'm really, really grateful for it, and such advocacy. And yeah, I'm a palliative care doctor advocating for clinical trials.
I love that.
I
And
love
where
it.
can
That's
people
so
find
cool.
you and follow you?
Yeah. Where can people find you?
Thanks.
Where can people find you, Dr. Kim?
Oh,
Where-
I am.
They
Oh, right.
they can come through me if you want, but
Oh yeah, I'm at I currently you know, I'm in Atlanta, but I'm on Twitter for better or for worse. You know, for better or for
I
worse.
love your Twitter. I love your Twitter. I love your
Yeah,
tweets.
yeah, but yeah, so but yes, I'm at Christine, and I'm also at the Emory Palliative Care Center, and I'm active in our Academy of Hospice and palliative medicine.
Wow.
Yep, and you can always just call me and I can hook you up with her.
Oh,
Mhm.
and you know, and there was a small world. Also, I want to put in a plug for getpalliativecare.org. Getpalliativecare.org is great. It actually explains what palliative care is in a non-scary way that makes sense. And you click, if you put in your zip code, it can show you where providers are in your area.
Oh, great. All right, great. I'm
Yeah.
putting that in the
Yeah.
comments right now.
Yeah, so
Yep.
that's probably the most useful. That's one of probably the most useful websites in the world. Getpalliativecare.org.
Palliativecare.com.
Awesome.
I
We'll
love
promote
that.
that. That's phenomenal. That's great. That is so
Wow.
great. That is so great. Wow, wow, wow. So thank you for joining us today. And we're doing Pink Table Talk this Sunday, Haley and Dr. Candace.
Oh,
And
great.
we're talking about a bunch of stuff about basically about, you know, all stages of Black breast health. So we're going to do that at 3:00 here on blackdoctor.org. And we have lots of events coming up. So look for our social media. We're going to be all over the place this summer as usual. And yesterday, Mo and Dr. Kim, as of noon yesterday, we have sent 10,401 Black women to clinical trials.
All right.
So we hit our
Wow.
10,000. So now, like, what's next? I got to figure that out. We're going to keep plugging away with When We Trial, and
That's
love,
right.
love my girls. But thank you for your support. Couldn't have done it without you.
Yeah, Dr. Kim,
Yeah.
thank you. Thank you
Thank
for
you so
being
much.
here and for being, you're on mute, but thank you for being a beacon of support and
Yes.
and helping people to understand how this cancer journey can be different, right? And the benefit of these services early on. So if you're watching, we've been talking about palliative care, and share this message, share this video on your social media, share it
Yeah.
on your YouTube, share links of it on your Instagram and all the places, and connect your folks to it, because it makes a huge difference when we
Yeah.
can incorporate these services early. It really does.
It does. And you don't have to be at the end of your life. This can happen in with
That's
stage
right.
1 cancer. So take advantage of it, learn
That's
about it, and tell people about it. So thank you. And thank you, Amgen, for the platform. Thank you, Black
Mhm.
Doctor.
Thank you
We
guys.
hope it's been relatable and reliable and real. So we set out to do every Wednesday night here on Black Doctor. So we'll see you on Sunday for Love My Girls and the Pink Table Talk.
All right.
Yep, 3 o'clock.
Bye.
Thank you. See you soon. Breasty love.
Yep.
Breasty love. Bye.
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 Bye. Bye.